So my program that I came here to work on at the NIH really has the goal of improving outcomes by improving detection and but not just everybody, but trying to help providers identify the small number of patients in their practice who are at greatest risk of progression, because everyone's overwhelmed. And so you can't tell providers, to spend more time with 50% of their patients, but you can say, look, here's how to identify the dozen or two patients in your practice that really are at risk. And most people can fit in the time to focus a little bit more on them. Promoting evidence-based interventions is important. There aren't very many in kidney disease. And then trying to get the different federal agencies involved in kidney disease, including IHS and CMS, to talk to each other. We use the chronic care model, which if you're an IHS, you're familiar with. And then we've also developed materials that are really meant to be used and developed within the Indian healthcare setting. And these are Indian healthcare specific. This is a sheet for providing patients the results of their eGFR up here and the urine albumin creatinine ratio, and it's written at a 4th to 6th grade level. And on the back of this sheet is some basic information on things they can do to make things to protect their kidneys. Also a one-page sheet on one side is eGFR for providers, the other side is urine albumin. And on the back of the tear sheet for patients is four basic points to get across to people with CKD. Now, I can't tell you that you need to spend 20 minutes with each patient to tell them about CKD, but you'll laugh me out of the room. But if I say, if you cover one of these points in 60 seconds, that's something you can do. You can extend the visit that long. And so we've actually given 2 or 3 sentences that you can say that get the point across. And this one is, you can't see on this slide, this one is what kidney disease is. This is what the tests are. This is the idea that it's progressive, that it's not going to get better, but you can slow how fast it gets worse. And this is a little bit about dialysis and transplant. Now, if you go through these in 4 visits, each in a minute or two, the patient won't have an encyclopedic knowledge of kidney disease, but they'll do a lot better than that data I showed earlier where they don't even know they have kidney disease. This is a lesson builder that we developed. This is on our website. If you want to do if you want to educate your patients, this gives all the materials, including pre- and post-tests and a curriculum that you can use, and it also meets the CMS criteria, so you could bill for this. Finally, I have a form for sending patients to a dietitian. The dietitian needs a referral, and this form includes very basic information. It's 1 page that you can fill out and sign. This is the bottom half, and then finally, I want to talk about a referral to a nephrologist. I don't believe in referring people simply based on what their GFR is. I think there are important reasons to send the patient to a nephrologist. If they have primary kidney disease like glomerulonephritis and they're going to need remittive drugs, you should send them regardless of what their eGFR is, as soon as you diagnose them. For preparing for renal replacement therapy, especially if the GFR is less than 30, it may be appropriate. People who have a rapid decline in eGFR, which is not typical for their disease or any disease, if it's difficult managing them, or if they have acute kidney injury. But simply sending everybody with a certain level of GFR I don't think makes any sense. This is a referral form, and that dietitian referral form is based on this. This is a fillable PDF, 1 page, which includes the history of if they have diabetes and how long, and whether albumin is present and how much, history of what their GFR has done over the past couple of years, and additional workup. And this lists some very basic screening tests which are worthwhile doing. especially if you're spending contract health money to send the patient out. If the patient shows up with some basic screening tests, which you can get done, that patient may be able to be told by the nephrologist, look, I think you have diabetic kidney disease. There's a few other tests I want. The results will go to your primary doc. If they're negative, I don't need to see you again for a while. But if they show up with no background screening tests, they'll be the nephrologist will say, I don't know what you have, probably diabetes. When you get these tests, I want you to come back again, which is inconvenient for the patient, also more expensive. Down here, it asks you to let the nephrologist know whether the patient knows that they have kidney disease, how serious it is, or if they'll need dialysis. Many patients will show up, and I can tell you this, it happens to me all the time. They say, I don't know, I have kidney disease? I need dialysis, and that's the useful conversation ends there, and usually nothing happens until the next visit. So just so you know that I'm not blowing smoke, I continue to see patients within Indian Health Service. I do it by telemedicine. This is my office at the NIH. This is Zuni. We have over 1,100 visits over the past few years, and including people with very advanced kidney disease. So what do I learn, actually, in Indian Health Service, which I'm trying to bring to the program that I direct now? Well, CKD needs to be part of primary care. That to do a better job, you have to improve the system. That usually means involving the non-physician health professionals. They're the ones who often really make the changes and implement them. The best way to improve kidney care is not to have a lot of kidney clinics. The best way to do it is to tweak and improve the way you address kidney disease within the context of diabetes care. And that's very much consistent with how IHS does it. And then focus, when it comes to referral, we'll focus on making sure the patient gets what they need from somebody who is competent to deliver it, not referring. If you simply think about referring at a GFR of 30, that means you almost have permission not to do anything until the GFR is 30. And you say, well, I refer all my patients at 30. I'm a good person. I'm a good provider. You've actually missed the opportunities. And in some places, people feel quite comfortable with a GFR less than 30 if they've managed lots of patients like this, like at Zuni. Other places, they don't. And so it's an individual threshold. So what does all this mean, and does any of this make a difference? If you look at the rates of ESRD caused by diabetes among different racial groups over the last 30 years, you'll see that it's going up in all groups. This is American Indians, African Americans, and the bottom two lines are Asians and Caucasians. The one group that went up but now has come down significantly is American Indians. And the risk of an American Indian with diabetes developing end-stage renal disease has decreased by about 30% in the last 10 years, which is a remarkable accomplishment. I can't prove to you that's due to the IHS diabetes program, but I believe that. And a lot of people who've looked at this very carefully, including skeptical people at the CDC, also believe that. So all of the work you're doing, even though it has its frustrations, is making a huge difference. And by effectively implementing the diabetes standards of care, there's been a huge benefit to the people that we all serve. So improving the care of people with CKD means changing clinical practice, especially where the high-risk populations are served, like Indian Health Service. You need to improve the care before the point of referral. Indian Health Care, is really the model that I use and that's looked to widely for improving care for people with diabetes and kidney disease. And the program that I work at now really benefits from what we continue to learn from the effective implementation of change in the delivery of care to people with diabetes. But here is my email address, and we have a website. All the materials I referred to, and plus lots more, are at this website. And if you have questions or you think there's something that needs to be developed to help you do a better job understanding what's going on, or even to educate the patients, please contact me. The best ideas come from people who are right at the front lines trying to make things better every day, and that's what I think most of the people on this call are doing. So I really appreciate your attention.